Okay, thank you very much. Sorry for the network glitch. So I'm taking practice question 3 here, and the recall that was given is a 25-year-old lady presented with severe hemicranial throbbing headaches, has 7 years history of recurrent hemicranial headaches with associated photophobia and phonophobia, no nausea or vomiting, neck stiffness or lateralizing signs. She normally takes NSAID which relieves symptoms. However, episode lasts more than 30 hours without treatment. So I was able to lay my hand on the question itself, which had some little changes, which is what I'm going to use to answer this question. Okay, so this is the question that was used in the exam itself. It says a 25-year-old woman presents to the emergency room with severe hemicranial throbbing headache with associated photophobia and phonophobia. We must note that in the first sentence here, please, am I still audible?
You're audible. Go ahead.
Okay, thank you. We must know that in the first sentence here, they put the photophobia and phonophobia in the first sentence as against what was recalled. Then there is no nausea or vomiting. Review of system was essentially normal. She has a 7 years background history of recurrent episode 3 per week of more to severe headaches, with most individual attacks lasting about 30 hours when general feels in painful distress, otherwise normal deficits, other systems are normal. So the follow-up question is, what is the most likely diagnosis? What are the diagnostic criteria for this disease? List specific elements of our history which fulfill the diagnostic criteria for this disorder. The headache is successfully aborted with a parenteral NSAID. List 5 classes of drugs that can be used for prophylactic therapies for a headache. So we go to what is the most likely diagnosis. The diagnosis A is migraine without aura, also known as common migraine. Then what is the diagnostic criteria? The International Classification of Headache Society diagnostic criteria is what is used to diagnose migraine. They have the 3rd edition, which states that patients must have at least 5 headaches lasting about 4 to 72 hours, whether treated successfully or untreated. Then apart from the headache, it must have definite characteristics, which are in natural location, pulsating quality, moderate or severe pain intensity, aggravation by or causing avoidance of routine physical activity. And then with this, there must be either nausea or vomiting, photophobia or phonophobia. So what features in our history support this diagnosis? Now, the lady, I'll go back to the main question. That was it. So the lady had to come to the emergency room. She had severe hemicranial headache. This fits into the diagnosis criteria. It's throbbing in nature, which she has. She has photophobia and phonophobia when she came in. This is also fulfilling the diagnostic criteria that I just talked about. Apart from that, the headache is unilateral, is moderate to severe, and has lasted about 30 hours. And the criteria said once is between 4 to 72 hours. Apart from that, she has background history of recurrent headache, which is likely telling us an history of migraine in her. And in the diagnostic criteria, it was emphasized that history is very important with all the other criteria listed. Being female is not part of the diagnostic criteria, but however, females are at they have a higher predisposition to having migraine. Also, when they examine her, they have normal neurological examination, which is actually the typical picture that is seen in the history of patients with migraine. All neurological examinations will be normal. Then she came to the emergency unit because of the headache. So she actually had avoidance of routine activity on that particular day, which is also part of the diagnostic criteria. So these are the things I can pick up from the history that support the diagnosis of migraine here. So what are the 5 classes of drug that can be used for prevention? For migraine, we have preventive drug and abortive drug. But for the preventive drug, we have antiepileptics, we have antidepressant, we have antihypertensive. We can use botulinum toxin. We can also look at serotonin gene-related therapy, peptide therapy, and NSAID. One of the things that has recently been approved by FDA between in the last 5 to 7 years is use of devices. So we can use transcutaneous devices, we can use hospital devices, we can use smartwatch. All these things can be used to abort migraine in people that have it. So we have the trigeminal nerve stimulation devices. We have the transcranial magnetic stimulator. We have the vasos upper arm device, which is a smartwatch that can be used to actually bit comes up. So that's the end of the answers to the question. I don't know if I can quickly go ahead with just a brief overview of migraine, sir.
Okay, all right. Go ahead.
Okay, so by way of introduction, the term migraine is derived from the Greek word hemicrania, and in Latin as hemigrania, and the French is migraine. Is a complex disorder characterized by recurrent episode of headaches, and most often is unilateral, pulsating in nature and throbbing. It's some cases it's associated with visual or sensory symptoms, and these are known as aura. These ones are like prodromes that happens just before the migraine headaches or maybe during the migraine headaches. And it has been said to have a strong genetic basis. More than 30 million people have one or more migraine headaches per year in the USA, and estimated 75% of all persons who experience migraines are actually women. It's less common in African Americans and Asian Americans when compared to white. The pathophysiology has been incompletely understood. So there have been many theories, but the ones that we know mostly are the vascular theories. I mean, for us that are non-neurologists. And in the vascular theory, they've talked about vasodilatation causing headaches and everything, but that has been thrown away. Now, current evidence suggests that there is a primary neuronal dysfunction, and this leads to sequence of changes intracranially and extracranially that causes the spreading out of the headaches in patients that have migraine or that are predisposed to it. There's also the cortical spreading depression theory, and is that there is a polarization, and this spread across the cortex. When this spread across the cortex, it can give us symptoms of aura. It can activate the trigeminal nerve system. When it's activated, this activates the blood vessels, causing vasodilatation and so also headache. It also increases the blood-brain barrier permeability. So that's just a summary about the cortical spreading depression theory. We also have the trigeminal vascular system theory, in which they said that there are pseudosensory neurons that are activated, and these sensory neurons activate the vascular large vessels, also leading to headache. We also have the sensitization theory, although it is not well understood yet, but they say that neurons become increasingly sensitive to nociceptive stimulations, and when they are increasingly sensitive, they can cause headaches in these people. They've also talked about the serotonin, which is not fully understood, and the calcitonin gene-related peptide, which has just been found out, and they've developed a drug against it. Also, they've talked about the right to left cardiac shunts in patients, being a pathophysiology and association of patients with migraine headache. And here they have patent foramen ovale ASD or pulmonary arteriovenous malformation. They've seen incidence of migraine higher in this set of people. A genetic component is also one of the things that must be noted, and the genes implicated are as listed below, this KCNK1 and all those genes that can be seen. Migraine run in families, and when it occurs, it's called familial hemiplegic migraine. There are classifications, which is what is listed here. Migraine without aura, with aura, these are the ones we know. Then we have chronic migraine. We also have chronic migraine with analgesic overuse. We have childhood periodic syndromes that are associated with migraine. Then we have what we call migraine variants. And here is where we have retinal migraine, ophthalmoplegic migraine. What they are just saying in all these places is that people present with migraine-like symptoms, but by the time you look at them very well, somebody can come in with a unilateral hemiparesis or heaviness of one limb, but it's always transient and it goes after a time. That one is called hemiplegic migraine. Patients can come with maybe headache and then symptoms of brainstem affectation, vertigo, imbalance. That one is called migraine with brainstem aura. This one, the brain is consistent and it's persistent for more than 72 hours before. That's called status migrainosus, and it requires emergency care. Also, we have retinal migraine, in which they can have visual disturbance, but the visual disturbance is almost always unilateral. And in the unilateral eye, you can have hemorrhages or papilloedema. And then there are migraine equivalents in which you might not see any
You can just have aura without any migraine. And this one is seen in patients with recurrent headaches. Most times they have had history of migraine for a while, but when they are coming, they just have the aura. And most times they are mostly older than 40 years and females. So what are the typical clinical features? That's what I've already talked about in the diagnostic criteria. So I'll just keep this slide in respect of time. Then with migraine with aura, the International Headache Society defines aura as reversible focal neurologic symptoms that usually develop gradually over 5 to 20 minutes and last for less than 60 minutes. It can just precede or it might occur during the migraine headaches. And most common positive visual symptoms seen is scintillating scotoma in them. The sensory symptoms can be cherry aura. They may have numbness around the mouth, the eyes, on one side of the face. They can also have heaviness of the limbs as an aura before they have the headache. The other physical findings that might be found are cranial cervical muscle tenderness. They can have occipital tenderness around their head, or this headache can be diffuse anyway. They can have features that looks like Horner syndrome, but most times it's transient. They can have bradycardia or tachycardia, hypertension, hypotension. They can have all these additional findings when they have the headaches. So we must also note the triggers we are all already aware of: stress, oversleeping, or too little sleep. They said can cause it. Then hormonal changes, menstruation, oral contraceptives. Then some medications too, which as listed above has been noted to contribute to patients having migraine, especially in people that have the risk factor. Head trauma is also one of the risk factors. There are also vascular risk factors that have been noted, which are what is listed above: increased level of C-reactive protein, interleukins, high blood pressure. All these have been noted to be part of what can cause migraine. So when the patient comes in, when we think that is not likely migraine, when there is temporal artery tenderness, especially in the elderly, you should think that we should, of course, it might be unilateral headache, but we should think more of other causes than migraine. When there is meningitis or meningismal signs in the patient, leg stiffness or any other thing, when there is, it cannot even fusion with it or any other mental changes, know that it's likely that it is not migraine. Then you search for other systemic symptoms, just as listed below: fever, weight loss, jaw constipation, seizures, confusion. The American Headache Society, they noted that when people comes with headache, that people want to do neuroimaging and some other investigations. So they listed 5 commonly performed tests that may not be necessary in treatment of migraine and headache. So when you think that you've taken a good history and the patients have migraine, there's no need to perform neuroimaging, because most times the neuroimaging comes out clean. So there is no need for it. Then don't perform computed tomography imaging for headache when MRI imaging is available, except if if it's an emergency setting. They don't recommend surgical deactivation of migraine trigger point outside of a clinical trial. Then there's no need to prescribe opioid or beta-containing medication as first-line treatment for recurrent headache disorder. They don't also recommend prolonged or frequent use of over-the-counter pain medications, because there can be headache that can occur. What are the other investigations we want to do? ESR therapy. This is in view of the temporal artery, what's it now? Temporal artery tenderness in the elderly that will give you a GCA. Then you also want to do visual test in case if the cause of headache is from something else and not from migraine. What are the complications? These are the complex stroke may occur, but it's rare. Most times people that have the vascular risk factors that have it. Other risk for stroke are female sex, cigarette smoking, and estrogen use. What are the comorbidities? Epilepsy, familial lipoproteinemias. They've talked about asthma during childhood being linked with migraine when they grow up in life. They've also talked about post-traumatic stress disorder. So these are all comorbidities, and the patent foramen ovale and atrial defect that I talked about earlier. So the treatment of migraine, you have to take a very good history. So history takes about at least 90% of your diagnosis. So you diagnose the migraine, you personalize care, you assess the disability that patients have, patient education, individual management, and stratified care. So for treatment, we have abortive therapy for acute migraine, and the abortive therapy is best given within the first 15 minutes. This is very helpful because it helps to slow down or reverse symptoms. You can also give antiemetics for those that have nausea and vomiting. metoclopramide can be given 10 milligram IV or 0.4 microgram per kg in one single dose. Then you want to give preventive therapy. This helps to reduce frequency and severity of attacks and also improve quality of life. And there is better response to when such patients come back to abortive therapy. Then you have to identify the triggers in the person by personalizing care and treat it. You have to manage comorbidities and follow up the patient. These are the drugs for abortive therapy, which I mentioned earlier. According to the ICAD guideline, these are the indication for prophylactic treatments in patients, just as seen on the slide. Then other non-pharmacological treatment, reduction of migraine triggers. So you have to counsel patients about all this. They've also talked about using of herbal medicine in management of migraine, and butter ball is a drug that has been said to be used, and they've seen some good outcome. But the challenges they have, like we have with other medications, is what's the dosage that will be given for such people, and how do we know that this is a particular dosage that will help the patient to be better? They've talked about biofeedback, cognitive behavioral therapy, yoga. All these have been said to reduce the frequency of attack in patients with migraine. These are the differentials for migraine: hemicranial continuous, subarachnoid hemorrhage, space occupying lesions, cerebral aneurysm. All this one can present with headache, but they have different characterization that will help you know it's not migraine. Then there are newer trends and future for migraine, Diabesat. And this has been used, and they said that it markedly reduced cortical spreading depression in patients. Other pipeline feature drugs that they are looking at are transient receptor potential vanilloid type 1 antagonist, receptor antagonist, serotonin receptor antagonist, nitric oxide synthesis inhibitors, but all these are yet to be tested. They require further research. Then the American Academy of Neurology and the American Headache Society guideline also have guidelines for usage of NSAID, and they've put some drugs as level A for NSAID use and other complementary treatment. And this is where the herbal medication comes in. So they said that the butterball is a level A recommendation for patients that are for preventive therapy. Then for level B, you can use NSAID, phenobrophene, ibuprofen, just as listed above. Herbal therapies, vitamins and minerals, all those are level B recommendation. Then for level C recommendation, too, is as listed below, according to the American Academy of Neurology. Then the International Classification of Headache. I just put this slide so that we'll know what chronic headache means. When it's more than 50 days in 3 months, status migrainous when it's greater than 72 hours of headache. So in conclusion, migraine makes a significant part of neurology consult, especially in their headache clinic. It has a strong genetic basis. The pathology is not completely understood. History and a high index of suspicion is important in diagnosis. So what are the take-home points? Migraine, we must know that migraine has a high genetic association. It can present with aura and without aura. We have to remind ourselves of the migraine variants, which are the ophthalmoplegic migraine, hemiplegic migraine, migraine with vertigo. Those are the ones with,
Okay.
Migraine with
Okay.
vertigo, and know that treatment can be preventive, and for abortive treatments, we should know when to use it. If you know that, sorry, I'm concluding already, that device therapy has been approved in management of migraine, and there are so many devices up there. I've mentioned 4 of them already. And then apps and behavioral therapy have been shown to be good in the management of migraine. Thank you for listening.
Yeah, thank you very much, Dr. Temi, for a wonderful presentation. So comments, contributions, questions, clarification. So from the chat box, thanks for a good presentation. This is from Dr. Shamsuddin. Does differentiation of migraine with and without aura has any clinic significance in terms of management? Okay, Dr. Ibrahim was saying, how about the use of triptans? Yes, I think you glossed over it in your slides. Then Dr. Jamila said, can you go over abortive therapy? Okay, so you can go ahead and answer those questions. The clinical significance. significance of migraine with or without aura in terms of management, and then go over abortive therapy. Okay, you can go ahead.
Okay. Thank you very much for the question, Saz and Mas. For patients with aura, the aura are the ones I mentioned that they occur maybe a few minutes or during the migraine, and without aura, they don't have those prodrome. So they've said that there are 4 stages in migraine, the post-prodrome. What I searched and what I read, the aura just lets you, just make the patient aware if they already know that this is what they usually have. So it made them aware that, oh, they want to have an event, and it helps them to maybe act faster compared with those that don't have the aura. And another thing about the aura is that during management and follow-up, you're able to counsel them to take notes, have a diary, to document their aura, and so to know when they will use the abortive or preventive therapy. But apart from that, I didn't come across any other distinct thing that will affect the management in patients with aura, migraine with aura and without aura. Then for the second question, abortive therapy. These are the medications used for abortive therapy. We have the SSRI. We see that in this patient, they said that they gave an IV medication. And when I searched, what they gave was actually an ergotamine, IV ergotamine. That's what they gave. So they can give triptans or ergots as IV if the headache is moderate to severe or very severe. And you have to give it in the first 15 minutes. That's when you have adequate control of the headache. And that's when it has been proven to act faster to relieve the pain and the post-stromal effects. Then you can also give calcitonin gene-related peptide receptor antagonists. Those are the remigertan and the ubrogeptan. These are abortive therapy. Ergot acolytes can be given, which are the NSAID that I mentioned earlier. And they've talked about combination products. When they have nausea and vomiting, we want to give antiemetics. Most times it's given as IV, but they can also take it as oral. So these are the abortive therapy. I know the neurologists in the house will shed more light on this. Thank you. I don't know whether there is any other question I've not attempted. So.
Okay, no. We'll still look at the chat box. Dr. Success, you can go ahead and make your contribution.
Okay. Good morning, senior colleagues and teachers. Thank you so much for that lucid presentation. I was lost. I was thinking you're a neurologist. Thank you. I just wanted to make some few comments, and I know my colleagues too will also add to this. Usually when migraine is associated with aura, we call it classic migraine. And when it doesn't, it's not, when it's migraine without aura, it's known as common migraine. Okay, so I wanted to talk more on, the newer medications we use that seem to have actually, gained some successes in the management of, migraine. Now we know that, so I'll just talk about the pathophysiology and then I'll bring them in just briefly. Like you said, there are so many, there are newer pathophysiologies, all in the bit of seeing how we can, try to reduce this, recurrence and of course, the extent of how the debilitating effects of migraine. And so, from the activation of the hypersensitive central generators, and this causes cortical spreading depolarization, which is important, which is an important key, in the pathogenesis of migraine. And of course, this not leads to meningeal blood vessel dilatation, activating the trigeminal system. This is where the problem starts, because when the trigeminal vascular system is activated, it now causes the release of vasoactive substances, neuropeptides rather, such as the gene-related peptide, the neurokinins, and of course kinins and so on. Now, if we can, of course, the major culprit in all these vascular neuropeptides is the carcinogen gene-related peptide. And so the new medications that are on now are actually trying to see how it can be targeted. So if you can target or inhibit the release of this carcinogen-related peptide. It may help you a lot. In short, we have them, and I think we've used it for some patients, and especially Erenumab, and it has actually yielded some successes. Although, of course, it's very expensive. I think one is about over 250,000, and the patient should take one. Will take one subcutaneously every month. Okay, so we have the GPANT. Okay, so these are the antagonists, that is CGRP antagonists. Okay, and we use them only for acute migraine treatment. Okay, so example is this, the Uribro GPANT and the Rimegeptant. Now, these are used for acute treatment. While things like the CGRP antagonists, okay, like the Erenumab, they are used for both, acute and prophylactic treatment. So currently, we advocate for this, of course, if the patient can actually afford it. Now, for the diagnostic criteria, there are this code we used to use, 5421. Okay, so 5421, 5, of course, at least 5 headaches. Then for the 4, each will last about 4 to 72 hours, whether untreated or unsuccessful treatment, treated. Then 2, the patient must have at least 2 of the following. Either it has to be unilateral, pulsating or thrombing, moderate to severe intensity, or of course aggravated by physical activity. So 2 of these is important. Then, of course, 1 of any of the following, whether vomiting, nausea, photophobia, and photophobia. Now, the ratio in male and female, for male and female, is 3:1. Now, and of course, this agrees with the DOUBT study. I want to also say that, so when there is hemiplegic migraine, of course, these patients will have lateralizing sign, which is a complication. So I saw that you say it was a variant. So by the time patients start having hemiplegic migraine, status migrainosus, these are actually complications associated with migraine. Then finally, I want to say that it is important that we must counsel our patients with migraine about avoidance of triggers, because this would actually prevent their coming again, coming down with the symptoms again and again. So they should try and, identify their triggers, and as much as possible, avoid the triggers. Unfortunately, some patients have also reported that even sexual activity can be a trigger for their headache. So you might know how to, counsel them in this regard. So there's one acronym for triggers of migraine, which is chocolate. That we used to use. So imbalance of late sleep, excessive and physical activity, travel, and then even excessive sleep. So these are my small contributions. Thank you again for the lucid presentation. Thank you.
Thank you, Dr.
Thank
Success,
you, Ma.
for your contribution. Okay. Dr. Temi, can you unshare your slide so that the next presenter, while I read from the comments from the chat box, so that the next presenter can.
Okay, sir. Thank you, sir.
All right. Dr. Blessing is asking, please, where do we place the device you mentioned? The devices you mentioned, you seem to have placed some emphasis on it. Abortive or preventive? Are they abortive or preventive interventions? Then Dr. Kopi say, please, this is directed to Dr. Success. Dr. Kopi is asking, please, what counsel will you give for sexual stimulus for migraines that he's concerned?
Thank you so much, Dr. Kopi. Like I said, we advocate for the use of this the CGRP antibodies, because they actually can give these patients, good relief. So, of course, you cannot tell your patient to stop, having, of course, you know what that means. It's just like when we said that sexual activity can also be a risk factor for hemorrhagic stroke. So you counsel these patients with, of course, treatment, and try to say as much as possible your migraine should be controlled. Okay, so even if you want to indulge in this activity as much as possible, okay, of course, then if sexual activity will trigger migraine. We, of course, as much as possible, don't also want to do it all the time. But the most important thing is let the migraine be controlled. Okay, so that's just the point I wanted to make. Thank you, sir.
Okay. So, Dr. Temi, about the devices, where are they placed? Are they for preventive or
Yes,
abortive?
thank you very much. I saw them more under preventive, but with my understanding, I think they can use them both as preventive and abortive.
I think they
And
are
like
more
I
for
said that,
prophylaxis. They're more for
yes,
prophylaxis.
prevent.
Yes.
Okay. Thank you, ma.
Okay.
Okay. While we're waiting, Dr. Jamila is asking for someone to help share her slide. So it's in the chat box. Is Dr. Ekele around? Can you help us share the slides? Okay. While we're waiting, okay, so Dr. Yahya is saying response to some of the medications for migraine varies between migraine with aura and those without aura.
Can I start? Good morning.
Yeah, all right, good morning. So you can go ahead.
Good morning, consultants, senior colleagues and colleagues. I'll be presenting a question. I'll be answering question 3B of the 2020-22 question paper.
Practice question.
I would like to acknowledge presentation done by Dr. Success and Dr. Abiola. They've answered these questions recently. So the question is, what is diabetic ketoacidosis? How do you make the diagnosis? What is the current ways of managing it? That's the principles of management. Then define diabetic foot syndrome. What are the principles of management of diabetic foot syndrome? So diabetic ketoacidosis is defined as an acute, life-threatening complication of diabetes characterized by hyperglycemia, ketoacidosis, and ketonuria or ketonemia. It mainly occurs in type 1 diabetes, but can occur in other forms of the diabetes. It occurs when there's absolute or relative insulin deficiency, which inhibits utilization of glucose and then leads to breakdown of fats into ketones as the fuel source. So how do you make the diagnosis of diabetic ketoacidosis? So it is made by when you have hyperglycemia of greater than 250 milligrams per dia or in a non-diabetic, and when you have ketonemia of greater than or equal to 3 millimoles per liter or significant ketonuria of more than 2 pluses on dipstick urinalysis. And then when you have acidemia, venous blood pH of less than 7.3 or bicarbonate of less than 18 millimoles per liter. So what are the principles of management of diabetic ketoacidosis? So preferably, a patient with DKA should be managed in a high dependency unit or intensive care unit. And you should aim at correcting the fluid loss by using IV fluid, preferably isotonic normal saline. Then correction of hyperglycemia with insulin, and that's soluble insulin. Then correction of electrolyte derangement, particularly potassium loss, because as you're managing, potassium is also being shifted into the cells. Then you correct acid-base balance, identification and treatment of the possible precipitant, then prophylaxis for deep venous thrombosis because they have high coagulable state, and then you educate the patient. Then for the fluid replacement, after ensuring the ABC of resuscitation, you place a 2 large bore cannula, then you use isotonic normal saline 0.9%. Then in DKA, they are thought to have severe dehydration, so they lose about 6 to 7 liters. So you aim at giving 1 to 2 liters in the first hour, then 1 liter in the second hour, then 1 liter in the over 4 hours, then 1 liter over 8 hours. So the regimen can vary based on the comorbidities or specific condition the patient has. Then you can also place central venous pressure monitoring. Then you also monitor the urine output and aim for 0.5 ml per kg per hour. Then you can also consider NG tube if the patient is vomiting or is drowsy, and there will be need for an oral medication. Then for the insulin therapy, preferably we use soluble insulin in an infusion at 0.1 unit per kg per hour, which will translate to about 6 units per hour in an average adult. Then you aim for the insulin, for the glucose fall to range between 3 to 4 millimoles per liter per hour, and then the ketones should fall 0.5 millimoles per liter per hour, or there should be a rise in the bicarbonate by 3 millimoles per liter per hour. If you're not achieving the above, so you double the rate of insulin infusion. Then you also monitor the blood glucose and then the ketones hourly. Then you should also check for the blood pH, the bicarbonate, potassium at intervals more frequently when you're not, depending on the situation. Then when the blood glucose is, when it is equal to less than or equal to 14 millimoles per liter, if the patient is not fully conscious, you can commence 10% glucose infusion alongside the normal saline to prevent hypoglycemia, cerebral edema due to precipitous fall in glucose. And you also continue the insulin until the ketones is less than 0.6 millimoles per liter, or the venous pH is more than 7.3. It's more than 7.3. So, but when the patient is conscious, and when the patient is conscious, you can switch to subcutaneous soluble insulin. So then during the management, you also need to replace potassium, because as you're doing your insulin infusion, potassium also falls. So when the potassium level is greater than or equal to 5.5 millimoles per liter, you will not necessarily need to add the potassium. But when it is between 4.5 to 5.5, you add 20 millimoles in each liter of normal saline. When it is between 3.5 to 4.5, you add 40 millimoles per liter, 40 millimoles of potassium chloride in each liter of normal saline. So then finally, you need to educate the patient. You need to educate the patient about the possible precipitants of DK and how to prevent it. Possible precipitants include wrong insulin dose or non-compliance, concurrent infection, myocardial infarction, pancreatitis, chemotherapy, antipsychotic, and patients that have undergone surgery. Then you also educate them about 6-day rules, whereby you advise them to take their medication even if their blood glucose is within normal range, and also to regularly check their random blood glucose when they are sick. Then you also educate them about the signs and symptoms of hypoglycemia and how they can manage it before they present to the hospital. Also, there's need for self-monitoring of blood glucose, whereby you teach them how to check their blood glucose by themselves with a glucometer. Then you also educate them about lifestyle modification, about their therapy, diet, exercise. They should stop smoking and alcohol ingestion. and then also educate them about need for compliance on their medication, and the need for regular follow-up. Then the next question is define diabetic foot syndrome. So according to WHO, diabetic foot syndrome is an ulceration of the foot distally from the ankle and including the ankle associated with neuropathy and different grades of ischemia and infection. So then the next question is, what are the principles of management of diabetic foot syndrome? So the principles include the following. It requires a multidisciplinary approach whereby you need the endocrinologist, ID physician, vascular surgeon, orthopedic surgeon, dietitian, podiatrist, nurse, and so on. Then you also need to have an optimal control of the blood glucose. You should aim at random blood glucose of fasting blood glucose of less than 7, or glycated hemoglobin of less than 6.5%. Then there's need to offload the wound and bed rest, because it has been known that when the affected limb is immobilized, there's increased blood supply, and then it also improves healing. Then there's need for debridement to ensure clean, healthy granulation, and also daily wound dressing with substances like honey. Then there's also need for appropriate antibiotic use, preferably when you take a tissue biopsy for culture, and the antibiotic appropriate for it. Then it is also important to evaluate and correction of peripheral arterial insufficiency to also improve healing. And then there's need to give deep venous thrombosis prophylactic with subcutaneous enoxaparin to prevent DVT, because they tend to be immobilized for some time. Then you also need to identify and correct risk factors. So the following are risk factors of diabetic foot syndrome that needs to be identified and corrected include peripheral neuropathy, foot deformity like Charcot foot, then abnormal foot pressure or inappropriate footwear, and then previous ulcer or amputation, poor glycemic control, abnormal joint mobility, and then concurrent diabetic complications such as diabetic retinopathy or nephropathy, and so on. So that's the end of the questions. Thank you.
Thank you, Dr. Jemina, for your presentation. So any comment, any contribution? You can share your slide there, Dr. Jamila. Dr. Ebikon, Dr. Okocha, Dr. Ebikon, if you're in the class, you can start sharing your slide. So any contributions, any clarifications? We can make our comments. Yes, we've taken these questions before. So, but if we have any clarification or contribution, we can contribute. Dr. Ebikon Brown, Dr. Kocha, are you in class?
Ebikon Brown just entered the class. I just allowed him in. I don't know. I think he should be inside. Brown, good day, Bishop. I think he's in the class. Dr. Brown, see him there in the class.
He's not responding. What of Dr. Okocha?
Hello, good morning.
Yeah, good morning. We can barely hear you, sir.
Can I?
Hello, we can barely hear you. We can barely hear you.
Can you hear me now? Good morning.
We're hearing you now clearly. Yeah. Good morning.
Can I present my own? I'll put it up on the.
You say?
Can I present my own question?
Yes. You can. Is this Dr. Okocha?
Yeah, we were waiting for you.
We're waiting. Yes, we're waiting for you.
And this is Brown.
Okay, this.